Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. And today we're going to learn about the options available to women who have been diagnosed with gynecological cancer. Our guest today is Dr. Dr Mueller, who is a surgeon who specializes in caring for women with gynecological cancers at Memorial Sloan Kettering Cancer Center, including at their Long Island locations. Dr. Mueller, welcome to Your Family's Health on the Voice of Nassau Community College, 90.3 WHPC. Welcome.
Thank you so much, Dr. Cook-Garard. I'm so pleased to be here and to join all of the listeners.
First of all, I start out by asking, how have you been doing during this pandemic? Has the virus affected you personally?
Thank you for checking in. I think that's an important thing we all need to be doing with one another. Yes, I'm doing very well. I would say the last year and a half did affect me personally. It was, as we all know, it was a challenge in New York with COVID, and I spent about half the year apart from my children and husband in order for them to feel safe and to be away from the worst that New York City was dealing with. And so that definitely left an impact on me. But I'm so grateful to say that my health is well, my children and partner's health as well. So we're all doing well right now. But, you know, everyone has a story.
Yes. I'm glad to hear that you're well and that you are doing well. You're in your family. Tell us a little bit about what made you want to become a gynecological surgeon and what was your career path that brought you to Memorial Sloan Kettering Cancer Center?
For me, looking back, I had a very strong interest in women's health in college in particular. I have a degree in women's studies, which is a liberal arts degree that focuses on lots of ways that how women in their education, in their personal development, emotional development, professional development, all the ways that our society and culture can make a difference and gain an understanding of the way that women interact in society. And so part of that was investigating healthcare for women. And that began an interest for me in an academic sense. But personally, when I was a teenager, around 16, my grandmother was diagnosed with a cancer and unfortunately passed away from that cancer. And she was a major influence in my life, a major mentor. And her death came at a time where I was very impacted by that in our relationship. And when I look back, I think my interest in cancer, women's health, all coalesced around those early years of my life. I didn't know I wanted to be a surgeon when I entered medical school. I would say, though, that working with my hands, the ability to make a difference using my hands in the service of women was immediately rewarding to me in training. And much of my life sort of was guided along the lines of, I like to work with my hands. I want to do something important for women's health. And cancer care in particular is very interesting and very rewarding because women's health, you know, these are mothers, sisters, daughters, teachers, leaders, lawyers, other doctors. These are all very influential women that we're caring for, no matter what the role they're playing. And to get women back feeling well, cancer-free, is one of the most rewarding things I could possibly do with my life. So it's, if anything, I call it a higher calling for me to be able to do work like this.
Mm-hmm. Thanks for sharing that story and thanks for what you do. Can you tell us a little bit about your practice as a gynecological surgeon? What type of cancers do you treat? How do you diagnose them? Tell us all about that. Fill in the blanks. Yeah, some of the questions.
As a surgical GYN oncologist at Memorial, I focus on surgical expertise here on a team. So some people may see a GYN oncologist like myself, and that person is doing their surgery, their chemotherapy, and really the primary point person. I integrate at Memorial as part of a specialized team. And in many ways, I consider it an advantage. So I have someone who comes alongside me when women need chemotherapy who have, the same kind of expertise, but in delivering systemic therapies, chemotherapy, targeted therapy, clinical trials. And that gives me an opportunity to really focus on my surgical expertise and what I can bring women. My day-to-day work, I would say if a couple of days each week, I'm in a clinic where I meet with women either with a new diagnosis of cancer or a concern for cancer, or women who are survivors of cancer and are coming to me for follow-up appointments, and spend a lot of time in those visits chatting with women, unpacking questions they have, concerns, establishing treatment plans, making plans for surgery. And then a couple of days a week, I operate. So for Memorial, we have operating rooms in the city. And although I do see patients out here on Long Island, as well as in the city, all surgeries are happening in Manhattan. And a couple of days a week, that's what I'll do is I'll operate. And then there's at least one day every week that is devoted to research, because we all have a strong commitment at Memorial, and myself included, on taking what we know now and our scientific understanding and what we would consider cutting edge, and always pushing the envelope to do better for our patients. And so part of that commitment is being able to spend time thinking of new questions, devoting my time to research questions that will improve women's lives.
Tell us some of the cancers. I know endometrial cancer, ovarian cancer, cervical cancers, vulvar cancers, rare cancer disorders. Can you fill in any other kind of cancers that you may see in your occupation?
Yes, so gynecologic oncologists like myself take care of GYN or gynecologic cancers. And that includes any of the reproductive anatomy that we would consider part of the gynecologic system. So that includes uterine cancers, cancers in the cavity of the uterus, which we have a different name for. Those are called endometrial cancers. The uterus also has a cervical portion, and so we also care for women with cervical cancers, ovary cancers, as well as the vulva and the vagina. That's the lower reproductive tract. And so those are parts of our bodies that cancers can develop. They're all unique and different and managed differently and need a different, treatment plan and discussion. And as a gynecologic oncologist, I take care of women with all of those cancer types.
Is that including breast cancer?
It does not include breast cancer, although for some listeners, you may have a life experience of thinking, well, I think I met a gynecologic oncologist who also did breast cancer care. And there are a few in the country, but that's not a common way that we actually take care of women with breast cancer in the United States. At this point, breast cancer specialists are totally separate from gynecologic oncologists.
Tell me in the practical portion of it, where I guess a lot of the listeners can really relate to, is what is the difference between a pelvic exam and a pap smear?
That's such a good question. And I love that you're bringing it up, because it rises to the top of all the issues I feel that come with how we've tied pap smears and pelvic exams, and they are not the same. So a pelvic exam is when you go to meet with your doctor, typically a gynecologist or a family medicine doctor, and you are in a position where you are having your pelvic exam, and typically something called a speculum is being used. And that's to allow the doctor to actually enter the vagina and visualize the cervix, which is at the very top of the vagina. Even if you don't have a cervix, you've had a hysterectomy perhaps in the past, pelvic exams with speculums are still used because the vagina is part of the reproductive system and needs to be examined. And so the speculum is what allows us to look inside the vagina at the vaginal walls as well as the cervix. We also, as part of a pelvic exam, would remove the speculum, and using 2 fingers of a gloved hand, that hand is placed into the vagina, and then the other hand is placed over the belly. And that allows us to feel the shape and the size of the reproductive organs, things like the uterus and the ovaries. And we're doing that because we're trying to feel for anything that doesn't feel quite normal. Is there a cyst there? Is there an enlargement of one of those organs? Is there pain? If there is pain, where is it? And we're also visually assessing through that whole thing. So is there any abnormality you can see with your eyes, as well as could you feel with your hand? A pap smear is part of a pelvic exam in many circumstances, but is just part of it. It is not the pelvic exam. And that's where a little brush very like soft bristled brush is used to collect cells from the cervix, which is the lower portion of the uterus. And a Pap test is a screening test for cervical cancer. Just like we have screening tests for breast cancer, like a mammogram, or colon cancer, like a colonoscopy, a Pap test is taking cells from the cervix to screen for either precancers of the cervix or cancers of the cervix. And you don't always need Pap tests with every pelvic exam, but we do recommend meeting with a gynecologist once a year, and as part of your well woman exam, having a pelvic exam. Does that make sense?
It does. And that leads me to the next question of how often should women get screened and see a gynecologist in general?
I recommend to my patients that they have at least a once a year check-in with their gynecologist. And I call these well woman checkups. And that's because you could have had a hysterectomy, even your ovaries removed. You could be in menopause, done having all your babies. You know, you could feel like, what's the point of going in? But honestly, once a year, meeting with someone who has expertise in women's healthcare, taking a look, feeling, examining, listening to you and how you're doing, head to toe, including your reproductive parts, is really important. And I emphasize after hysterectomy because the vulva and the vagina are still part of your body and need to be reviewed, examined, checked in on by an expert, because obviously cancers can develop in those parts of the body, or even other things that aren't cancer, but you're not able to look and see and evaluate that part of your body that easily. And so it's good to have an expert check in. Separate from that are Pap smears, which the guidelines used to be yearly. If you look back, 10 or 15 years ago, it was pretty normal to get a Pap smear every year. Mm-hmm. Thankfully, we've made progress and advancements, and now Pap tests come with what's called an HPV test most of the time. And when you've combined a Pap test, which is looking at the cells of the cervix, which with an HPV test, which is looking to detect the HPV virus in the cervix, which we know is contributing to most of the development of cervical cancers, that's a really powerful screening test that doesn't need to be done every year as long as it's normal. And our current guidelines recommend every 3 to 5 years getting a Pap test. Those guidelines may change in the future. And so that's why I try to make sure I really emphasize to women, get your annual well woman exam, even if you're not due for your Pap smear, because the rest of your body still needs a checkup.
Yeah. How often, how early should you have your first Pap smear?
We recommend age 21.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about options available to women who have been diagnosed with gynecological cancer. Our guest today is Dr. Jennifer Mueller, who is a surgeon who specializes in caring for women with gynecological cancers at Memorial Sloan Kettering Cancer Center. So Sloan Kettering is just not in Long Island, but is also branches in Manhattan. Am I right with that?
Yeah. So we have a lot of, we call them satellite clinics or satellite centers, but we also emphasize it's one MSK, meaning you're not just getting a building with our sign on top of it. It is literally, I, for 10 years, lived in Manhattan and I have come out to Long Island every week. I'm the same person going to each of those places. We really try to make sure the quality of care is the same no matter where you go. And so, yes, we have 2 sites in Long Island. We have sites in Westchester. We have several sites in New Jersey, as well as the city location. And that's to really enhance the convenience of, gosh, I have to go in and meet someone or have screening tests or blood work or a CAT scan. And it's a lot to come into the city for all of that. And so that's why we've decided this is the best option for patients, is to branch out and be where people are in the community.
Tell me, why are gynecological cancers, why can they be so challenging to treat?
The challenge with gynecologic cancers are that they're inside the belly. The majority of our anatomy isn't visible to the eye. If I had something on my arm or my foot or my face, I could see it, I could track it, I could say this isn't normal from what I'm used to. Maybe it would just be more obvious and I could hopefully get in and have someone check it out. When you have your organs inside your belly cavity, something could be in there that you don't feel any different. Your uterus and ovaries are generally quite small. You could make a fist and look down at it and you could fit your uterus, cervix, both ovaries and tubes all within just the palm of your hand. So when something like that is developing an abnormality, we don't really have any reliable testing that's going to tell us what's wrong. So that's why we really encourage women and try to get the word out about paying attention to what your body's telling you and to seek an evaluation if anything seems to be wrong that isn't going away. A couple of days of bloating, but it goes away. Okay, fine. But if you've been feeling bloating, or you're full really quickly from meals, your bowel habits have changed, bladder habits have changed, or you have persistent pain and it's been like 4 to 6 weeks, that's not normal. And we want you to come in and get checked out. But you can imagine those aren't symptoms that are really specific to ovarian cancer or uterine cancer. Those could be indigestion or irritable bowel syndrome, urinary tract infections, lots of things that are more common. But that's why we get the word out, because it's never wrong to seek an evaluation from your doctor or your healthcare provider and say, this isn't right for me and it's still going on and I don't have an easy answer as to why. And I want to persist and find out what's going on, because often it's that repeating the visits, coming back and saying it's still not better, that can help us get to the diagnosis. The one symptom we have that I try to really highlight, because it's definitely abnormal and women can notice it, is spotting or bleeding, particularly when your body is done having periods. We call that after, menopause. But even if you're still having periods, say your periods start to get really heavy and that's not normal for you, or you start to bleed in between your periods, those are all considered abnormal signs. And even if it's one episode of spotting, or a brown discharge, it doesn't have to be a lot. It could just be one time. And honestly, that counts. We want you to come in and get checked out. And what we mean by getting checked out is often a pelvic exam, sometimes something like an ultrasound to try and take a look at the anatomy inside your body that you can't see and can't report back to us about. And then typically a biopsy of the lining of the uterus. We call that the endometrium. You can often do that in the office itself. Takes maybe 5 minutes. And that's a really, really good way for us to get a little extra information, because bleeding is not normal and it really needs an exam.
Based on your experience, because the symptoms are so hard to really figure out, has it been your experience that women come in having a very advanced stage of cancer?
Truthfully, in my experience, that's less common. I just want to champion the women that I have been interacting with over the years. Women are paying attention. Good. They are, most of the time, are seeking help. What I do hear, though, is unfortunately, sometimes providers will say, well, I don't know. I've done X, Y, and Z tests and they're all normal, so I think you're okay. And I think the one message I would tell women listening is persist. If your bleeding is still there, if your pain is still there, you've had a bunch of tests, but they're all normal. That doesn't mean there's not something wrong, and it's okay to keep persisting and, making sure your doctor is listening to you. The other piece of that that I think is that I can listen for in what you've just said is a lot of cancers present with advanced stage. Like ovarian cancer is a very good example of that, where it's really common for women to be stage 3 or stage 4 when they're diagnosed with ovarian cancer. But that's not because women aren't noticing symptoms. It's because we don't have reliable screening tests for that. We don't have something like a colonoscopy or a mammogram or a Pap test that's going to help us detect these cancers earlier. There's a lot of research going into that. And I do honestly think in my lifetime, hopefully within the next 5 to 10 years, there will be something like a blood test, or even not quite a Pap test, but something similar, ways to get at detecting cancer cells early so that these cancers won't be advanced when we are able to detect them. But the belly cavity can hide cancers, and things like ultrasounds and CAT scans aren't perfect. And, sometimes I hear women tell me, I had a CAT scan just last year and it was perfectly normal, but I was having pain. And now a year later, I have this CAT scan and it shows disease, advanced ovarian cancer. How did this happen? And that's because we don't have the right tests, and we need to make that progress. And we're all working hard on it. But until we have something better, we are helping women understand the symptoms so that they can get evaluated by their doctors and hopefully get to that diagnosis as soon as possible.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about the options available to women who have been diagnosed with gynecological cancer. And our guest today is Dr. Jennifer Mueller, who is a surgeon who specializes in caring for women with gynecological cancers at Memorial Sloan Kettering Cancer Center, and including at their locations on Long Island. So, Dr. Mueller, who is at most risk for getting gynecological cancers?
It depends on the cancer that we're discussing. And as you can imagine, we're caring for women with a lot of different cancers. But if we talk about the more common types and risk factors, we could start with ovarian cancer. This actually, our lifetime risk for just someone who doesn't have any family history or genetic risk is under 2% in our lifetime. So it's actually not one of the most common cancers. About 20,000 women are diagnosed each year with ovarian cancer, but it is a very deadly cancer. And so we kind of consider every woman to be at risk who has ovaries and fallopian tubes. And so we pay attention to the symptoms. But if we looked a little more closely at women who have ovarian cancer, about 20% of women who have the most common type will carry a mutation in their own DNA that they were born with, typically in the BRCA genes, BRCA1, BRCA2, that put them at risk for ovarian cancer. And the risk ranges between 20 to 40% lifetime risk of ovarian cancer. And if you compare that to what we call baseline risk of under 2%, that's a significant increased risk. So we look very strongly for family history or for people who have family members or they themselves personally have a risk have a gene mutation in BRCA1 or BRCA2, or even we call it a family of genes that are all related to what BRCA1 and BRCA2 do. There are some other genes that are less common. And so the impact of genetic testing in families with high risk, families who have ovarian cancer in them is very important, as well as testing women who have a personal history of ovarian cancer. It's now standard of care to test all women for genetic risk so that family members can also have counseling and testing. So that's ovarian cancer. There's also endometrial cancer. That's cancers in the lining of the uterus. And about 5% of endometrial cancers are based on genetic risk. That's something called Lynch syndrome. So that's not as common, right? So 5% is a little lower than the 20% risk that some women can have with genetic risk for ovarian cancer. So the vast majority of women with endometrial cancer are going to have spontaneous cancers, ones that we weren't born with a risk. But we do know those women can have risk factors. The very biggest one is any reason that the body just has too much estrogen in it. And that's a hormone that acts a lot like a fertilizer in the lining of the uterus. We have another hormone called progesterone that balances it out, but some women have, problems like polycystic ovarian syndrome, or diabetes can do this, or they're overweight or even obese, meaning their body mass index, their weight to height ratios are more in favor of being overweight or obese. And we have fat cells that can make a hormone like estrogen that acts like that fertilizer to the lining of the uterus. And endometrial cancer in particular has a lot of research going into how to modify. Can we prescribe things like exercise, ketogenic diets? Can we improve insulin resistance? Can we correct the polycystic ovarian syndrome with medical treatments so that women don't have extra estrogen in the body? And so those are some of the known risk factors, but the research isn't, definitive. There's still a lot of active interest in that area. The other major risk factor for some other cancers, and I would put them all in the same basket, vagina, vulva, and cervix, is HPV. And we touched on that a little earlier in our interview today. HPV is the human papilloma virus. It is so common. Literally, I always tell my patients, walk in any room, anywhere, look to your left and look to your right. Chances are everyone you're looking at has HPV. It's just a very prevalent virus. And it's not your fault. And honestly, it's not like chlamydia or gonorrhea. It's not like that. It's just a very common, pervasive, it is sexually transmitted. It is a virus, so it's going to live in your body, and it puts you at risk for cancers of the cervix, the vulva, and the vagina. It is nice, and this is a good opportunity to mention that we do have a vaccine that helps protect against the very common strains of HPV that contribute to over 90% of the cancers of the cervix, the vulva, and the vagina. It's called Gardasil. And we are trying to catch up a lot of adults to get that vaccine. Mostly teenagers at this point are getting it as part of their routine child care, both boys and girls. But men and women up to the age of 45 can get that vaccine, and it does provide protection against the viruses that contribute to those cancers.
Where can people find out more information about you and where we can find you?
That's actually really easy. You can literally go into any web browser and you could type my name, Jennifer Mueller, MSKCC. And if you do that, you will come right to my page. And my page includes, where do I practice? What number do I call if I want to set up an appointment to talk to Dr. Mueller? And it also includes like a bio about me where I touch upon today, how did I come into being a GYN oncologist and doing surgery in women's health? I talk a little bit about the story with my grandmother and my college education and my personal story. But I also include, the research that I work on, some of the studies that I have open and enrolling. There's a picture of me there so that you can actually see my face, and a few videos that you can actually tour the NASA Long Island Clinic site. And that's true of the entire department. So that's a really great, if you go there and land there, but you want to find out more about the chemotherapy doctors or some other, doctors on the GYN service, it's an easy way to get to all of those places.
And what is the one thing, if you could leave with our female audience when it comes down to gynecological health?
Listen to your body. And that is different from blame yourself if you, quote, missed something. Literally listen to your body. If you feel like something is off, unapologetically pick up a phone or go to a portal and get an appointment with someone you trust who will listen to you. If you don't feel like the person that you first chose is listening to you or is trustworthy, pick a different person, but be persistent. Listen to and trust yourself. And the other piece that I really want to make sure women hear, if you've ever had a cancer diagnosis, is it's not your fault. There's not one single thing you should ever look back on and say, if only I had done X, Y, or Z, or if only I had done that, then I wouldn't be where I am, because that's not true. And cancer is not a death sentence. We've made so many strides now that I want women to know that if you ever are facing a GYN cancer, that there's room, lots of room for hope and to feel encouraged and to know that the surgery and the treatment and the science are with you, and we're continuing to make progress. So to have hope.
Thank you for being here, Dr. Jennifer Mueller, who is a surgeon specializing in caring for women with gynecological cancers at Memorial Sloan Kettering Cancer Center, including at their Long Island locations. We hope you stay safe and continue to be healthy. And thank you for being our guest today, and an awesome practitioner, may I add, who has a caring approach.
Thanks so much for having me.
This is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the nursing department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.